Over to you, sir.
Okay. Good evening, everyone. It's a great pleasure to have you all here. I'm Dr. Omkaro, working as a medical advisor at Hydro Healthcare. Our topic of discussion for today is experience sharing program on managing postpartum hemorrhage. The purpose of today's meeting is to have a better understanding of the management of postpartum hemorrhage and the role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since more than 25 years and has more than 300 products in its portfolio. It has 21,000 employees globally and is among the largest manufacturers of ARVs, API, and FDF in the world. It has 36 state of the art manufacturing facilities and has its presence in more than 126 countries. It also has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. It also has wide product range encompassing multiple specialties. Hetero has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. Now, I would like to also introduce the speaker for today's meeting, that is Dr. Santosh Jaybhaye, sir. Sir is currently working as a practicing obstetrician and gynecologist and freelancing gynecology endoscopic and laparoscopic surgeon in Navi Mumbai and Raigad. He is also the joint director of Om Sai Multispeciality Hospital and Advanced Gynecology Laparoscopy and Hysteroscopic Surgery Center in Kamothye, Navi Mumbai. He is also the president-elect of NMOGS. He has done his post-graduation in obstetrics and gynecology from SET GS Medical College and KEM Hospital in Mumbai. So with this, I welcome you, sir. I welcome all the delegates and hand over the session to Dr. Santosh, sir. Over to you, sir.
Thank you, Dr. Omkar. Let me share the screen first so that we can
yes,
go ahead. Is my screen visible?
Yeah, it's visible, sir. Yes.
Okay, so our agenda for today's meeting is to discuss regarding postpartum hemorrhage and role of carbetocin in the management of postpartum hemorrhage. So, by definition, postpartum hemorrhage is at least 500 ml of blood loss following vaginal delivery or 1000 ml of blood loss following cesarean section. PPH is common and can occur in female, even in those female who are not at the risk. It's a leading cause of maternal mortality in low-income countries as well as a primary cause of nearly 25% of maternal deaths across the world.
Just a second, sir. Sir, there is a box of videos on the right side of your screen. If you can just minimize it. Yeah. Yes. Now it's better, sir. Yes.
Yeah. Okay. So, as I said, it's responsible for 25% of maternal deaths across the world and is a leading cause of maternal death in the low income countries. The same information is coming up here. It's leading cause of maternal death, accounting for 35% of maternal death across the world. Global incidence of PPH is 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. As far as the Indian data goes, 38% of maternal deaths are attributable to PPH and 25.7% of the global deaths take place in India, and 2/3 of these deaths attributed to PPH. So India has an unexpectedly high maternal death rate, and PPH is the largest contributor. Etiology of PPH, the common causes: tone, thrombin, trauma, and tissue. It goes by the name of 4 T's of PPH. Tone is uterine atony, inability of the uterus to contract, leading to continuous bleeding. Thrombin is related to the coagulopathy. Trauma, it could be a uterine trauma or trauma to the birth canal, cervical trauma, or vaginal and perineal lacerations. And tissue, it's related to the retained placenta, retained clots, or an abnormal placentations. Clinical findings in PPH: abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine tone, maternal tachycardia, vaginal bleeding. Keeping in mind all these things, PPH can be divided into 4 parts. in the first, it's a compensated PPH where the loss is between less than 1000 ml, amounting to around the blood pressure changes are not seen and patient feels palpitation, dizziness, and tachycardia. Then the mild PPH, where the blood loss is between 1000 to 1500 ml. There's a slight fall in the blood pressure and patient may complain of weakness, sweating, and tachycardia. Moderate PPH, in which the blood loss amounts to 1500 to 2000 ml of blood loss. There's a marked fall in the blood pressure and patient complains of restlessness, pallor, and oliguria. In case of severe PPH, the loss is between 2 to 3 liters. There is a profound fall in the blood pressure and patient, we may face a maternal collapse, air hunger, and anuria. Diagnosing postpartum hemorrhage, initial evaluation, when you are suspecting a PPH, there should be a rapid initial evaluation where you judge the vital parameters of the patient, presence of tachycardia, hypertension, assessment of the vital signs and blood loss needs to be done. After examination, at the time of evaluation, assessment of the entire genital tract for laceration, hematomas, and signs of uterine rupture. This is to look for the trauma part of the causes of PPH. Manual examination of retained placenta to look for any retained placental beads or any placental cotyledon that has been retained inside. Assessment with bedside ultrasound to check if the uterus is contracted or not. Even this can be done by clinical examination. And evaluation of the uterus to check whether there is any component of uterine inversion in the as a contributor to PPH. Laboratory assessment includes a complete blood count to check hemoglobin, hematocrit, platelets. Coagulation studies, this is to look for the thrombin part of the PPH. Now, I think the same things have been mentioned here. Poor uterine tone, you can palpate the uterus and see whether uterus is completely contracted or it's a relaxed, boggy, and soft. Uterine fundus can be palpated, may be felt above the umbilicus if uterine cavity is filled with blood clots. Investigations include full blood count, coagulation profile, urea, electrolytes, and the management mainly goes to oxytocin, prostaglandins, and ergot alkaloids. Patients who are not responding, we can think of going for uterine balloon tamponade. And if things are not working, then surgical management is to be thought of. Tears and trauma, we can examine the uterus and the genital tract for looking for tears. During cesarean section, lateral extensions of the uterine incision can be seen. Extragenital causes very rare, but subcapsular liver rupture and rupture of ovarian and splanchnic vessels. These are just to complete the list, but these are extremely rare causes. Investigations include inspection during cesarean section, and if the patient is a normal delivery, then ultrasound to look for the signs of hem, hematoma and pelvic collection. Management in this includes repair of the genital tract trauma and intractable cases may be pelvic artery embolization. Coming to third cause of retained tissue, retained placenta and membranes, they can be identified by manual examination. If required, examination can be done under anesthesia so that patient is relaxed and you can examine patient thoroughly. And management includes manual removal under general anesthesia. Coming to the last cause, coagulopathy, a patient will present with continuous bleeding in spite of a contracted uterus. Investigations include coagulation profile, full blood count, urea, and electrolytes. And management include immediate replacement of blood and blood products. And if not responding, surgical management if the patient is not responding to medical management. The point here I would like to emphasize is the attempt should be made to identify the cause in a woman with bleeding. But at the same time, if the patient is going into the shock, parallelly, the resuscitation measures should continue. Now, coming to the product which we are stressing today, that the Carbetocin, it is available at room temperature, stable formulation, and a convenient vial presentation. Oxytocin, especially the oxytocin which we use, is to be refrigerated, but the Carbetocin can be kept at room temperature. Heat stable formulation of oxytocins are not available. Those are now available with Carbetocin. Previously, even Carbetocin used to was needing refrigeration. With recent updates, those things are not required. And whenever the refrigeration is required in the resource poor countries, it is very difficult for a clinician to be assured of cold chain transport and storage. And sometimes uh, improper cold chain storage can lead to ineffective action of the drug when it is used. Use of uterotonic agents, when to use it? Prophylactically, it is to be given at the time of crowning of the baby's head or at the time of delivery of shoulder. It can be given at the end of second stage of the labor, that means immediately after delivery, or sometimes it can be given following delivery of the placenta. This is a therapeutic use. Prophylactic use can be given as a part of active management of third stage of labor and therapeutically for management of PPH. The molecules which are available are oxytocin, carbetocin, ergometrin, symptometrin. It's a combination of ergometrin with oxytocin and oral formulations like misoprostol. Now, carbetocin will not go into the details of the biochemistry, but what we need to understand that carbetocin has been created by making several changes in the structures of the oxytocin that has helped us to prolong, say, half-life and reduce its enzymatic degradation. It's a long-acting synthetic analog of oxytocin. Its therapeutic indication is prevention of PPH due to uterine atony. And 1 vial contain 100 microgram of carbetocin in 1 ml solution for injection. Now coming to clinical evidence, efficacy and safety of oxytocin, carbetocin versus oxytocin. It has been proven by multiple trials as comparison of carbetocin with oxytocin, comparison of single dose carbetocin with bolus oxytocin, comparison of single dose carbetocin with continuous infusion of oxytocin, as well as safety and efficacy of carbetocin as against the misoprostol with oxytocin combination. We have discussed these things. The certain things which needs to be known. Oxytocin can be used for induction of labor, but carbetocin cannot be used. Induction and augmentation of labor are the indications of oxytocin where you cannot use carbetocin. But prevention of PPH, you can use carbetocin. Again, carbetocin cannot be used for treatment of PPH, but its role is main into the prevention of PPH. Coming to this WHO champion trial, will not go into details of the trial. Let's come to the conclusion of the trial. What it says, carbetocin is not inferior to oxytocin for prevention of blood loss of at least 500 ml or use of other additional uterotonic agents. Now, what we need to understand here is efficacy of carbetocin is at par or slightly better than oxytocin, but oxytocin has its own disadvantages. The major disadvantage of oxytocin is its cold chain maintenance. Cochrane review, it says for women undergoing cesarean section, carbetocin resulted in a statistically significant reduction in the need of therapeutic uterotonic agents compared to oxytocin. Also, carbetocin is associated with less blood loss as compared to symptometrin for the prevention of PPH in women who have vaginal deliveries and is associated with significantly lesser side effects. What are the guideline recommendations? According to WHO, carbetocin is the second line drug. According to the guidelines from Canada, carbetocin 100 microgram IV bolus is a first line dose for prevention of PPH. FIGO has recommended carbetocin in one of its recommendation for PPH management, and majority of the gynec organizations across world has endorsed use of carbetocin for preventing uterine atony as a therapeutic measure. Coming to some of the cases, I'm presenting this first case where it was a Gravida 3 Para 2 living to 39.2 weeks. She had a history of atonic PPH in previous pregnancy. This pregnancy, her hemoglobin is 9, polyhydramnios, and a prolonged second stage of labor. This is typically a patient who is at a high risk of developing PPH. Normal vaginal delivery, baby of 3.6 kg. The intervention that we did was giving carbetocin 100 microgram when at the time of delivery of anterior shoulder, and without immediately after delivery of shoulder, placenta got separated immediately, and there was hardly 300 to 350 blood loss, and no additional uterotonics were required, and uterus was firmly contracted. Second case, this was a G2P1L1 IVF pregnancy, 37.5 weeks. She was a placenta previa anterior type 2 previous cesarean and a scarred uterus. Elective cesarean was done. Baby weight was 2.9 kg and carbetocin was given at the time of placental delivery. And this patient also didn't face any atonic PPH. The blood loss was around 600 ml, but no extra uterotonics were required in this case. If there are any questions, we can take the questions.
Okay, sir. So, thank you so much, sir, for sharing your valuable insights. It was such a wonderful session. Now we move forward to the next part of our session, that is panel discussion, where we'll be having frequently asked questions and real-world scenarios which arise. So, sir, considering the sir, can I share the PPT from my end, or
If you want, I'll stop sharing.
yeah,
Yeah,
just a second, sir. So, sir, considering the use of carbetocin as a basically first-line drug to prevent postpartum hemorrhage, what are the specific advantages or benefit does it exactly offer in this case?
as compared to other uterotonics that are available, the probability of failure of prophylactic measures is very less in carbetocin. Sometimes you give pitocin, oxytocin, and you still need other uterotonic agents, but that probability is significantly less with carbetocin. One thing, and the most important is the you don't have to be worried about cold chain maintenance. That is the biggest advantage. You can you can use it directly even without refrigerating it.
Okay. Thank you, sir. Moving to the next question, sir, what are the specific, we can say, patient profiles or cases where we can anticipate postpartum hemorrhage?
Like polyhydramnios, large babies, previous history of tonic PPH, prolonged second stage of labor, placenta previa, patients with PIH. These are the cases where we need to be very much prepared to anticipate PPH and if to tackle PPH if at all it happens.
Okay. Moving to the next question. So, sir, doctors generally use oxytocin for labor induction. So, in such cases or in such scenarios, can carbetocin then again used for prevention of postpartum hemorrhage?
You can use. There is no contraindication for using carbetocin in this scenario.
Okay. Means we can say that in the same patient, if oxytocin is used later
Yes,
for
yes,
prevention of postpartum hemorrhage, we can use
yes.
carbetocin.
We can use.
Uh, Moving to the next question. So, sir, as IV route is the preferred route generally, if we modify the question a bit, are there any scenarios or cases where IM route would be preferred or preferable?
Uh, Nothing. But we, as a protocol, we use it as an IV.
Okay. Means in majority of the cases, IV would be
Yeah, most
preferable
of
and
the time. Because
recommended.
patient is indoor, patient is admitted and IV access is already secured. So why to prick the patient unnecessarily?
Okay. Means there is no specific scenario or need
No,
in which IM would be required.
no.
Okay. Thank you, sir. Moving to the next question. So, sir, considering the safety, if we consider the safety and tolerability of carbetocin, how it is observed in patients after administration?
Uh, we have not seen any major side effects in any of the patients in whom carbetocin has been used. For that matter, side effects even in oxytocin were not very much noticeable. So it's very well tolerated.
Okay. Yes. Thank you, sir. So, sir, if the patient is not responding adequately with carbetocin, then in order of preference, which additional uterotonics would you
We'll,
use?
we'll, we'll go ahead with methyl ergometrin or the carboprost. and misoprostol.
Okay.
We
Thank
generally
you.
avoid oxytocin as a therapeutic measure if carbetocin has not worked, because sometimes just because the receptors have been blocked, oxytocin may not work, and that will unnecessarily waste our valuable time in managing the patient.
Okay. Thank you, sir. Sir, considering the advantages or specific benefits of carbetocin, if we compare it with other uterotonics, so what are the specific advantages?
We have discussed, I think, the same thing, because the results are better, efficacy is good, storage requirements are not there. These are the major advantages, and of course, the efficacy and effect probability of failure are significantly on the lower side.
Okay. Means we can say that the cold chain requirement, which is not there,
Yeah,
adds up.
that is, we have repeated it multiple times. That's the biggest advantage.
Okay, yes. So, sir, should carbetocin be kept as a reserve drug or it
No,
should
it
be
should
used
be
as a
used as
first
a
line?
first line. It should be used as a first line for prophylactic for prevention of BPH.
BPH. Okay. So, moving to the last question, sir, if you have to summarize the use of carbetocin, considering its efficacy or safety, and in which patient it should be used, so what would you comment on that?
We are very much happy with the use of carbetocin, and we are very much relaxed since the carbetocin has been introduced, because the probability of PPH has gone down significantly.
Okay. So, thank you so much, sir. This brings us to our end of our session. So, thank you so much for sharing your valuable insights and guiding all the delegates regarding efficacy and safety of carbidocin, in which patients it should be used, what are the factors we should look for, and what are the specific advantages of carbidocin. So, I would also like to thank all the delegates for their active participation and engagement. So, this brings us to our end of meeting. And again, thank you so much, sir. So we can end the meeting.
Yeah. Thank you very much.
Yes, thank you, sir.